Hi, everyone. Welcome. We're on Pharmacy Operators Podcast. Today, we have as a special guest Ryan Johnson from Float Health. Welcome, Ryan.
Yeah, thanks from really a lot for having me. Appreciate it.
So, Ryan runs a company that is most relevant for the specialty pharmacies that are involved in infusion services at the home. Ryan, do you want to give a brief description of what Float does and a little bit about your background as introduction?
Yeah, absolutely. Float is a highly managed marketplace for home infusion. What that means is that when specialty pharmacies get a referral, they need to attach a nurse. And we have a large and growing pool in many geographies, 8 states so far, where nurses on their days off from the infusion center, from the hospital, can opt in to take those visits, and that helps the pharmacies staff more prescriptions, help more patients get onto these drugs that keep them happy and healthy and at home. And for me, my personal background, originally a biologist, then went into nursing, went into the ER for about 10 years, and along the way, moved up into leadership, but also have a dad that was a specialty pharmacy patient. So that's kind of what first opened up my eyes to this other aspect of healthcare. And ultimately helped me recognize kind of this problem that we're solving from two different sides, that of the patient and then also that of the health system at large.
Very cool. So let's dig into that just a little bit more. So I know that a lot of, founders in the space of the staffing world come through the field of business or recruiting. You actually came in through, your own experiences in the emergency room department. And what you saw in those ERs that connected, oh, there's like a business problem here that needs to get solved for. What did that look like?
Yeah, I think the analogy that we often talk about it through is like you can add another lane to a freeway, and that doesn't reduce the congestion of traffic. It just causes more traffic, more cars on the road. And so when you think about staffing as just a supply problem, you're not actually recognizing the whole system. And so when you think about hospital impaction, just adding more beds, adding more nurses, that doesn't solve the root cause. What you really need to do is treat the patients that have chronic conditions but aren't getting served, so that they aren't coming to the ER when they have the symptoms of their disease. They aren't getting admitted. And specialty pharmacy is unique in the healthcare industry because it actually does do that proactive treatment for patients that, again, like keeps them happy and healthy. And that healthy piece means that they stay out of the ER, they stay out of the hospital. And now you don't need as much infrastructure for the health system, and you're getting better health outcomes. So it's really a win-win, obviously for patients, but even for the economics of our healthcare system nationally.
Yeah, that's pretty interesting. I think that impacts not just, I guess, specialty pharmacies, but hospitals and kind of the incentive programs they have for Medicare and the treatment of the chronic patients. Yeah, going in and out of hospitals is never a pleasant experience. If you're able to be at the home and get taken care of there, it's definitely a overall better experience. Was there any sort of patient journeys you saw that triggered the idea of, there's something wrong here that we could do better at?
Yeah, I mean, literally thousands. So the bulk of the patients that are coming through an ER, any ER on a given day, are not emergency patients. Like they're patients that are having maybe an urgent issue, but again, they're usually precipitated by some chronic condition flaring up. So, think of a Crohn's flare or a patient who has immune suppression that didn't get their treatment and then now has an infection, something like that. If they had gotten their treatment before, then they wouldn't be congesting the ERs. So I saw that thousands of times, but specifically, personally, I saw it through my dad. So growing up, he was a specialty pharmacy patient that couldn't access specialty pharmacy regularly because there weren't enough nurses, or the nurses that were available weren't comfortable starting IVs in the home, running meds on pumps, or they weren't available frequently enough. So he'd miss treatments. And when he would miss too many treatments, he'd get admitted to the ICU. And so that was just a fact of life growing up. I kind of remember like, oh, dad almost died once in the mid 90s and he got readmitted again a couple of years later, just for simple things, but because his immune system wasn't brought up to par. When I moved back from the East Coast, now as a nurse, I could give him his treatment in the home. And I saw that when he got his, at the time, like every 2 weeks, when he got his IVIG, then he could do whatever he wanted to do. He could work full time, have a great career. He could be, go water skiing. He could go running. He could go on long walks. He could play with his dog, all of those things. And so his quality of life was always high when he was treated, but when he would fail to get treatment, it would crash. So just keeping him up at healthy levels kept him, from visiting me at my day job, which was the ER.
Yeah, that's pretty crazy. I mean, that's a very, very, very deep experience in what a patient journey looks like. I think it's kind of interesting to me. There's more family involved in your experience in float health, which is you are building this with your sister-in-law. I guess there's kind of this like warning in the industry, or not in the industry, but in business in general, never mix family and business. What did your partnership start out as, and then um, are there things that you found that allow you to execute on things that would be harder to do with a stranger or someone who's just someone you've met that you do business with?
Yeah, totally. I think the general caution is probably correct, but I, would say that you would never want to say never. I think sometimes it makes a ton of sense. And for myself and my co-founder and sister-in-law, Christy, it makes a ton of sense. It kind of began because we were that classic complementary skill set, and that was huge. But then we did have to reconcile with like, well, how do we handle also being family members? But again, in our specific case, like it worked out really well. I often joke, I've known Christy for over half our lives. He's married to my brother, and they dated for a long time before that. So I always kind of joked that my brother gave me the sibling I always wanted that he could never be. But she specifically, her and I just have that foundational relationship that really helped when we were starting something new and continues to, because we can have a level of candor that you couldn't otherwise have with someone that was strictly like a professional relationship. And especially when you're starting something new and in that 0 to 1 phase, having someone that is like not only that you can talk to about it, but is literally going through it with you side by side, I think is undervalued when people are starting things. Like you can have all the motivation, be driven by your mission as much as possible, but you have moments of overwhelm, of doubt. You have questions, and to have someone that you can like really trust is, I think, undervalued. I would recommend more people think, is there someone that I'm very, very close to that I could start this thing with? And if you have a relationship that can withstand that, I think it can be huge.
Yeah, that makes a lot of sense. So now talking a little bit more about what happens operationally at a specialty pharmacy when it comes to nursing. Something that kind of shocked me about the specialty pharmacy world is that, somewhere between 40 to 80% of referrals go unstaffed at typical specialty pharmacies, like they just don't find nurses for them. And I imagine that's probably why you have a lot of pull, because that doesn't just impact the revenue from nursing, but also from the drug, and also, patient loyalty, provider loyalty. Uh, when it comes to this, what are kind of the stakes here, and then what are some of the things that Float does around this?
Yeah, I think the stats are scary. I think that to your first part of your question, so much of how a specialty pharmacy works is variable between one pharmacy and another, but also between one intake coordinator at a pharmacy and another intake coordinator at that same pharmacy. Or a certain director of nursing might run their region differently than another. And that's not to say that that lack of consistency is a bad thing. It's usually just a reality of having a system that was built, 4 decades ago and doesn't utilize a lot of technology. And that results in this high rejection rate. It's obviously much higher for acute patients that are getting discharged, tonight from a hospital and need to go on antibiotics than it might be for a patient on a biologic or a biosimilar that isn't due for 3 weeks. But that is also a smaller section of the 3 million patients that are getting specialty pharmacy infusions. And really, that sliver of patients that are able to get specialty pharmacy infusions today in the home is grossly underrepresented by all those that qualify. So, to one of your points, what ends up happening when a given prescription isn't filled, then you get a negative signal to the prescriber that
Mhm.
there isn't sufficient nursing supply, or the pharmacy can't source a drug, or they don't know. So then they stop sending in more referrals. Conversely, if you're able to have a great nursing partner that is able to increase your fill rate, then every prescriber can gain confidence that every patient that they see can get the treatments that they need to stay happy and healthy. And that becomes this virtuous cycle that draws more patients into this realm, keeps them out of the hospitals, keeps them out of the infusion center, which are a higher side of care, cost of care, and definitely out of hospital beds. So that's really kind of the magical moment where you start to recognize that there's a whole blue ocean of opportunity for the specialty pharmacy industry. We know that there's new drugs coming on market. We know there's a big push from payers to treat these patients proactively and to do it at the lowest cost side of care, which is the home. And all those things start to work if you can staff because you have appropriate nursing. So I think that's like the big unlock.
Yeah. What's interesting about the industry is the therapeutics have advanced so far, and all of the other infrastructure is so outdated. Like the tech, the kind of procedural things, the infrastructure that underlies, how nursing happens, how intake happens, various aspects of it are pretty uh, way less advanced than what the drugs can do, which is very surprising, right? Like the
It
drugs
is.
take 20 years to get to market, whereas the tech takes, a couple, like maybe 2, 3 years. And so it's surprising that it hasn't caught up as
Yeah,
quickly as
and that's like a really kind of profound insight because it's got to be driven by the economics. Like we know the pharmaceutical companies, they invest a lot into developing drugs, but there's very little investment in trying to solve this, last mile problem, the staffing problem within specialty pharmacy. And then that becomes the rate limiter for the whole industry. So you can bring, hundreds of new drugs through the approval process, bring them to market, but if you can't actually get them into the patients that need them, then it was all for naught. So I think a shift towards thinking about, well, how can we invest in our labor force within specialty pharmacy? And that is, highly skilled registered nurses in the home. How can we invest in that? That's what's going to unlock stopping thinking about them as like a cost center, but actually as a revenue generator.
right as part of your product, as like part of the
Under,
offering that makes it a great experience for someone. Another stat about you guys that shocked me was, I said earlier the referrals go 40 to 80% unstaffed. When float gets involved, you bring that up to 95%. What are like that's pretty crazy, right? That's a jump of sometimes more than double of what someone does today. How do you guys achieve that, and what was kind of the insights that led to, oh, this is how we can solve this?
yeah, so this is kind of the key disruption of how float operates compared to any internal nursing source or any traditional like nursing agency source that specialty pharmacy would use. To kind of put it into a nutshell, historically, everyone has always tried to do one-to-one matching between nurse and a patient. So it means that, if Eesha is a nurse and Ryan's a patient, then you might get assigned to me. And if you're due every, week and you prefer Fridays, then I have to make sure that my schedule from works like for my life, and that your schedule works for all of your other patients that you see. And that just creates this multi-layered logistical problem that starts to have domino effects whenever a patient needs to reschedule, or a nurse needs to reschedule, or someone's out of town and wants to take vacation or anything like that. What Float does is, using our highly managed marketplace, we're able to aggregate more nurses that are higher skill, but we also do a one-to-many approach, which is fundamentally different than the rest of the industry. And so what that means here is that if you have a patient, Ryan, that needs to be seen every other Friday, then Eesha can be the preferred nurse that sees that patient most of the time. But we can have a different nurse, or maybe two or three different nurses over time, that Ryan, as the patient, starts to aggregate as a list of preferred nurses. And now this is the big flip, is that instead of orienting around the nurses' schedules and how you route and distribute them and pay them PTO and account for when they have a sick kid, you're orienting around when the treatment is due. So you're orienting around the patient. And this is truly like a patient-centered approach that is honoring the treatment schedule above everything. So what does the prescriber say this patient needs? Let's put that at the center and make sure that we fill in nursing as completely as we can by having as many nurses as we need to do that. And again, typically, like for care continuity, it looks like this one nurse is seeing that patient most of the time. But whenever you need to fall back, you have that each patient has a deep roster of nurses that they also love, that are also familiar with them. And that one-to-many approach ensures that my adherence as a patient is near 100%, if not 100%. I'm going to get every treatment that my doctor wants me to have. That's going to keep me out of the hospital. That's going to keep me happy and healthy.
That makes a lot of sense. I think in software development teams, there's this concept of bus factor.
Mm-hmm.
So if one of your teammates got hit by a bus, would your, service or tool or whatever fall over because they have some kind of knowledge that nobody else has? And it seems like the way the industry has historically operated is a bus factor of one. Like there is one nurse that knows that patient. And if they are suddenly gone for some reason, which, there is high turnover in these roles, you're basically left with a patient who is going to get slotted with someone they have no familiarity with, and they don't know that this is coming and it could happen suddenly and all this other
Or
kind of
more
stuff.
likely, they'll just miss their treatment altogether, and then they wind up, having, MS flare or something like that.
Exactly. And so, from a supply chain sort of lens to it, or reliability of service lens to it, this makes a ton of sense. And if the patient knows to expect this and they know that it leads to more reliable service, I mean, that's just better for everyone.
100%. I love the bus factor analogy. That's totally appropriate. Never thought of that specifically before, but the business world has discovered this many, many times. Like, obviously, in the bus factor, the key man risk, like, you can't just have one person that everything is dependent on. And every other system would solve around this. So, you're going to route to one server, and then if that server goes down, you're going to have multiple backup servers. This is that same concept, just brought to care delivery, but doing it around, again, like solving for that risk and making sure that the patient is at the center of it, ends up being better for everybody.
Yeah, much less risky than if you're completely dependent on one person.
Mm-hmm.
Another kind of interesting thing I learned about Float was some of the kind of metrics around the cost of staffing.
Mm-hmm.
So, what's weird about specialty pharmacy is nursing is a necessary thing, but most of what happens in the business is centered around the drug. Like the margin comes from the drug. And so, nursing historically, people have looked at as a cost center and they kind of optimize around that. But it also makes sense to invest in sort of enhancing your resources around here. You guys take a very interesting approach where you have kind of like a tech enabled piece to it, and you also have the actual nursing services. Kind of, can you talk through sort of what the impact is to businesses because of this?
Yeah, totally. And it's multi-layered, but at the heart of it, when you're thinking about nursing as a cost center, where it's a loss leader, it's the cost of doing business so that you can make your margin on the drug, you're having a relatively short-sighted view of what the value is that nursing is actually bringing. And that's why I kind of implied earlier that I think when pharmacy leaders, and there are a few pharmacies that we've done case studies with where we've demonstrated this, when they start to think of nursing as a revenue generator, as a growth vehicle, then that totally flips the script. So instead of trying to optimize the productivity of every single unit of nursing, which is totally like a hospital model. It's like a throughput model. It's based on like, how many patients can we turn over in each bed, or even an infusion center, like how many patients can we run through each chair with a minimal amount of staff. That model doesn't work in the home because each patient only has one sofa. They only have one recliner to sit in. And so when you flip that and think, well, actually, every one of these nurses has a capacity that can help us service a certain number of patients every week or every month or whatever that is, then you're actually starting to grow your business. And that is, I think, the key unlock. The other layer here is that when you're managing your nursing in-house or you're managing your agencies, often you, or always, you're having to pay for their travel time. So you're paying for mileage, you're paying for that windshield time. When they're in-house, you're also having to account for their benefits, for their PTO, and then the management infrastructure that has to sit above them. So surprisingly, when we do these case studies, we actually show that even though on the per hour basis, it might look like the salary at an hourly basis for any other nursing source, whether that be in-house or a nurse agency in the traditional sense, might look like the same or slightly cheaper than what float would be. Float is actually much, much cheaper because we're not a fixed cost. So float is a variable cost that you can really use to capture more referrals, grow your pharmacy business, and we are flexible in that. And so again, like that's this other facet of the model that is unique, but then also helps the pharmacies to grow without growing their expense base at the same time. And then the technology layer just adds in this third component, which is so much of what our platform does is, yes, automate a lot of the selection and matching and provide an EMR for the nurses to chart in that's really resilient to auditing, which helps reduce the burdens on the pharmacy. But also, we handle so much of the care coordination in terms of resupply sheets, scheduling the next visit, giving the nurses like updated treatment plans, prescriptions, or new drugs come to market and educating them on that, and removing all of that burden from the pharmacy's education team, from the pharmacy's billing team, also just makes them more efficient so they can process that growing volume without increasing their other cost centers, their admin costs. So we're kind of helping them win on both sides. They're able to grow their revenue, but also decrease their expense base. And so that's like the key, again, like unlock of this type of model.
Yeah. What I find interesting about that is we had another operator on the podcast talk about how they mitigate risk when they're not quite clear on the projections coming up. Like they know they need to be ready for a potential ramp up, but how do you balance that with not wanting to overhire or like underhire, not be ready for something like this? So it feels like this is a great solution for folks in especially that situation where you're like, okay, we got this like limited distribution drug, or we got this new clinic we're opening up, or new pharmacy we're opening up in some new region, and you don't quite know exactly what's going to happen. And so this allows them to have that flexibility also to decrease the risk basically of overhiring or putting resources where it's not warranted quite yet, but you want to be ready for it.
Yeah, exactly. Like let their team grow the pharmacy, get those new drugs onto the formulary, have their salespeople go wild, and then know that they have this variable capacity that they can immediately lean on.
Yeah, that's pretty cool. So you talked a little bit about the EMR aspect of what you do, or the sort of compliance auditing aspects, documentation, billing. I think in the world of pharmacy, this is a very manual paperwork industry with a lot of paperwork that gets filled out, submitted. Everything's very expensive, so there's a lot of insurance overview on things. What are some of the things that you guys saw where you were like, we need to do something around this? Like what?
Yeah.
I'm guessing you started as just staffing, and then something probably happened that triggered, oh no, we should probably do something here.
Yeah. So, my life before this, ER nurse, technically by afternoon and evening, because that was the shift that I did. But by day, I was a home infusion nurse for my dad and for some other patients. So I got to see before float what the state of the art was, and 100%. It's papers that the nurse prints at home before going on the visit, or um, and then usually has to like screenshot with their phone and then convert to a PDF to email, totally unsecure, not compliant, and then also impossible to audit because it's a PDF, it's an image, and so one of the very first things we built at Float was our first version of our e-chart, and I don't even know like what that looked like relative to what it is today. But to this end, and we aren't the only people solving this, but it makes way more sense, obviously, to have an EMR. And then the nurse is able to document in real time. There are audits that can happen live. So, was a vital sign abnormal? Was there a note about it? Was a vital sign on time? Is the treatment ending on time? Was there a note about why it went over? Did you contact the pharmacy to get approval because you had to slow down the rate? So you went 30 minutes over auth. All of those things technology is perfect for. And so the EMR is just one example of that. But the dividends are not just to the nurse having a more robust chart. It becomes one that requires less auditing, but it also is one that gets to be submitted right away. So traditionally, the pharmacies are having to hound their nurses to like, hey, you saw this patient 2 weeks ago. Or maybe you're 3 visits behind on a certain patient. We need to get those so that we can bill insurance. But when you're using it through our platform or any platform, you're able to submit that at the end of the visit. The chart is submitted, it's bundled with the invoice. It can go through on our end, internal audits before it's shared, and then that invoicing team at the specialty pharmacy can submit for reimbursement. They can pay out the nursing source, and their whole ARAP system can just be much more seamless and much, much less of a burden, which is huge.
Yeah. Did this start because you saw how slow it was for the nursing to get paid for? Was that basically why this happened?
Not explicitly. It was more that for the pharmacies, when they go too many days beyond when the visit happened, then they start to be non-compliant because they don't have an updated plan of treatment. They also can then be unable to get reimbursement from the payer because it's too distant in the past. And during that whole time, the whole like 30 days of badgering the nurse to try and get this paper chart submitted, they're having to invest a ton of their time into that follow up. So it was really from thinking about from the pharmacy's perspective, what would they want most, and then that helped them get paid sooner. And then kind of the happy side effect is that we're able to pay our nurses sooner because the nurses are submitting immediately after the visit.
Yeah, that makes a lot of sense. When we think about sort of the nursing experience in this whole journey, so, the tech helps with kind of these aspects of all the paperwork they hate doing. But there's of course that serving the patient that is part of one of the reasons why people become nurses. In this particular case, where they're going into the home, not a hospital, they're going into take care of a patient they're going to have a long term relationship with. Uh, what can you walk us through like what does a nurse encounter? How do they prepare? What does the patient journey look like for from their perspective?
Yeah. The thing about nurses is that they're just good at doing. So as much as it might seem kind of odd to go into a stranger's home. It's not that different than going into a stranger's, room in a hospital, or having a new patient come into your clinic suite or something like that. So it's something that nurses are accustomed to. What nurses need in order to do that is kind of the necessary information, and some of that is clinical. So what is the prescription? What How is this drug going to be administered? Like, what's the titration rate, et cetera? What are my modalities that I can use to mitigate any adverse reaction? What supplies do I have for that or for the rest of the visit? And then when in the home, there's kind of some fun aspects too, which is like, does the patient have a dog? I love dogs. Or does this patient like, watching K-pop because you're listening to K-pop because that's the type of music that I'm into. And so that's kind of the fun piece that we're able to provide to our nurses, is the just-in-time training, but also the relevant patient details that kind of accelerate that connection with the patient. And so in reality, when you do get into these homes, these patients are already super grateful. You're coming to them. They aren't having to go into the infusion center or the hospital. You're delivering a drug that they rely on. And so you're a guest, and you're like a welcomed guest in their home. And to that end, like, they often will, bake cookies, or, ask like what you're watching on Netflix so you can watch it together. And once the infusion is running, then like the IV started, vitals have been checked, and the infusion is running, you're just kind of taking intermittent vital signs. And so from a nursing perspective, it's a relatively easy job compared to a hospital job. Plus, it's one of the rare times that as a nurse, you actually get to connect to your patients. And you usually don't get to do that in any other setting. So you do start to develop these friendships, and you can also see the impact of the care that you're giving these patients, because you're seeing their lives improve, like literally right before your eyes, week over week. And that's amazing. Like, that amount of like fulfillment is, I think, super rare, probably in any job, but even within healthcare, and definitely for most aspects of nursing.
Yeah, it's pretty special. I think one aspect to this is how the journey of the nurse. Um, so we've talked about sort of the tech side a little bit, the patient side a little bit, and we've talked about sort of the positives on this side. When it comes to the tech side, let's talk a little bit about some of the areas you guys have seen gaps, or you've seen sort of um, ways where things could be improved. Where are things going, really, is what I'm asking here. So, have you walked into places where the software is actually making things harder? Or have you seen where there's areas where, oh, actually, we do need a solution coming or emerging here where there isn't one today?
Yeah. Um, I think that there's a ton of surface area here when you start to orient the whole industry around like what I was kind of talking about before, but maximizing the patient's adherence to the treatment. And so there is, in the whole industry, there's a paucity of actual interrogation of the details of the business. So like, if you ask a given pharmacy, what is your time to staff? They often don't know. If you ask a given pharmacy, what is your fill rate for acute versus chronic, or for drug X versus drug Y, they often don't know. If you ask a given pharmacy, even like, what are your labor costs when you actually add on the windshield time, the benefits, the admin overhead, et cetera, they often don't know. And there is so much data here. Like, we have a ton of it. But I think the next opportunity for the whole industry is for more pharmacies to start to log and audit that data, and then importantly share it, so that they can actually make it a system that, again, is trying to increase speed to staff, increase that fill rate, and ultimately increase the adherence of the patient, not just because it's better for patient outcomes, like 100% it is, but at the end of the day, they're a business, but it's the best thing for their business to do. Because if you have a patient that is prescribed 25 visits a year and they only get 15, then you're missing out on a lot of potential revenue for that patient. And you multiply it by the tens, the hundreds, the thousands of patients that you have per branch, then that really starts to be meaningful to your top line. And when you're actually able to move forward in like a quantitative way, you start to reorient around maximizing that adherence, and your business is better off while also making the patients better off.
This is such an interesting point. We see something very similar on the front, like on the intake and prior outside of things, where people usually don't know what is their overall sort of time from intake to the patient being ready, or what's their approval rates, or I mean, there's so much data there to leverage. They don't know how many fills they do of a particular drug often. They don't know, who are their highest hitting providers. Some do, but like most could not tell you these numbers. And I think it was a little shocking to me with such an operationally heavy business why this would be the case. But I mean, it's just what we were saying at the very beginning, which is all the tech is like decades behind, and the drugs have come up way faster than the tech has caught up with. And so there's this sort of, I think, not that knowledge base built up in the industry of this is how we can use data driven approaches to drive different aspects of the business. And there's many aspects to these businesses, right? They're very complex, a lot of different pieces to it, so it's probably hard to keep track of everything. And so I think partnering with people like you probably help, take that chunk and make it visible and make it so that they can tease apart the things that could be optimized and improved and things like that. uh,
Totally. And to come to the defense of the specialty pharmacies, they have had to focus on logistics so much that I'm not surprised that they haven't had the opportunity to actually think about optimizing the business. The good news is that that data is there. And to the point, some pharmacies are great at it or are becoming great at it. And they're the best partners for us too, because then they start to recognize like this becomes a growth engine for us when we solve the nursing problem and we can optimize the rest of the business. So whether it's with float or without, I think any specialty pharmacy that actually looks at those top line metrics and how they impact their top line and their bottom line stands to gain a ton in this space, because there's only more drugs coming onto the market, there's only more patients that need this, and there's only more payer incentive to bring patients to the home.
So, when it comes to using metrics as a way to lead operations, I'm sure you've seen, a bunch of different pharmacies operate in very different ways, some of them data driven, some of them not. In terms of your mental model of what good looks like, what have you, without naming names, what are the ones that you're most impressed by, and what did it feel like in terms of their culture and the way that they work? What tools are they using? That kind of thing.
Yeah. In terms of optimizing the business, I think the best example are those few specialty pharmacies that are actually thinking about the time to staff and then also like every step along the way. So are they actually trying to increase their fill rate because they are maximizing time to staff, and that will actually get a patient on to treatment sooner so they can begin generating revenue from that patient tomorrow instead of waiting 2 or 4 weeks where they've missed a couple treatment cycles. And so there's layers of nuance there. I think from the technology perspective, the things that they are doing is they're leaning into the platform approach, and so that can be come in many flavors. We utilize AlayaCare through some of our pharmacies, but we also have our pharmacy portal where pharmacies can directly send referrals to us. In either of those cases, when you're utilizing electronic submission rather than a call or even an email, then what it allows us to do is kick off our whole automated process. So we end up our system will intake that referral, parse out all the details, notify the local float nurses to that patient that are qualified for that treatment type, that are certified to see this patient type. So is it pediatric, is it an adult patient or whatever, and have been educated in that specific treatment as well. And then we can notify them, collect their availability, present that collective availability to the patient, and then the patient is able to select what time works best for them. Again, orienting around the patient's time. And so that technological layer allows all those automations to happen, and the output is time to staff. So if the pharmacy is measuring on that, they can be very objective about, well, like what nursing source is working best for me. So all they have to do is audit the numbers. They don't need to know about the process. So I think that's one thing that we've just seen. The pharmacies that use our pharmacy portal love it, and they have better outcomes. The other piece, which you didn't really ask about, but I think is important to touch on, and you said don't name names, so I won't say the one in particular that I'm really thinking of, but those pharmacies that actually invest in care coordinators, whether they're called patient care coordinators or some analog, they're the ones that develop the relationship with the patient, that make sure the patient has what they need, that if prescriptions change and the pharmacy wasn't notified, they learn about it. And I've seen this with my dad and his specific pharmacy, who's incredible. I made him switch to this pharmacy because they're so great. And it has just increased his quality of life a ton, but also increased his outcomes greatly. And I see that with a bunch of other patients through several different pharmacies that actually invest in that human layer, that connects the patient to the pharmacy. So, the nursing is always going to have a direct connection to the patient, but I think it's important for the pharmacy to have that direct connection too. And again, I think it should be thought of as a growth engine. I should think that the right quantitative decision maker at the pharmacy is thinking about the ROI of their patient care coordinators based on patient adherence and patient retention. So are they able to keep their patients on their service and from switching to another pharmacy for decades? That's a worthy investment.
Yeah, that makes a lot of sense. I think there's an interesting push now to kind of operationalize with AI a lot of the pieces of the pharmacy workflow, but this one piece, the care coordination for patients, feels like one where maybe that should be the last. Maybe like all the other pieces you could put whatever AI you want into, but that piece feels a little special that should be held on to. That's my like opinion as
Yeah.
a yeah, that one feels like one that is a little special.
Yeah, it kind of gets into the nuance of like, well, what is AI and which type of AI are you using? Because AI can be, and any automation can be great up until a certain point. And so I think that like the point at which you introduce a human in the loop for any of these processes is super important. And some patients like are going to confirm electronically their visit with us because that's their preferred method. There's just they would rather interact with a text message or a bot or something like that. Some patients want to talk to someone on the phone, and we should honor that and not think of it as a problem, but thinking of it as an opportunity to increase retention of that patient, and basically like give the patient what they need, give the user what they want, and let it be custom. So we use a lot of AI internally to build our product, to optimize our product, and then even to deliver the outputs of our product to our pharmacies, to our patients. But you still need that human in the loop whenever you're going to be touching another human, and also whenever anything needs like less than probabilistic judgment. So anything that needs to be deterministic should have a human review.
Yeah. I guess this goes really well into the next question, which is 3 years from now, the specialty pharmacy that have figured out people, systems, processes, what does it actually feel like to work there from the nurse's perspective? And what does it look like from kind of the leadership perspective?
Yeah, not to answer this with a totally different direction, but I think in 3 years, you're going to see that nurses won't work at specialty pharmacies. They will work with them as partners, as like revenue generating partners. But I think it makes way more sense for the specialty pharmacy to focus on being a pharmacy, like get those distribution agreements with the pharma companies, get the contracts with the payers, get your sales team into the providers' offices, and then let a nursing partner solve the rest of that problem and be a partner in that you don't have to manage, that you don't have to treat as a cost center, that doesn't have to be a loss leader for you, and actually just think of it as a true partner that is helping you actualize on your pharmacy business. I think that will be the next step change within specialty pharmacies, and the pharmacies that do that earliest will outcompete everybody else.
Yeah, it's pretty interesting. I think that most businesses at some point focus on a core competency and outsource like almost everything else. And most businesses don't really recognize that soon enough. But as soon as they do, something kind of clicks and things move very quickly. So it'll be interesting to see what emerges as sort of that special thing that pharmacies hold on to, and the different pieces that they kind of modularize and put together with, for example, like the nursing component. Um, Lastly, for the ops leaders listening in, we have directors of specialty pharmacy, infusion center directors, VP of operations. What's the one thing you would want them to take away from this conversation and do potentially differently, or think about in their day to day that would be kind of a lesson from this conversation?
Yeah, I think without like repeating what we've said too much, like this week it's Nurses Week, and the theme this year is like the power of nurses. And I think that it's important to recognize the power of nurses is that they are bringing like the hearts, the minds, and the muscle to any space that they touch. And that's important in specialty pharmacy as well. So I think just recognizing your nursing partners will go a long way to make sure that you have the ability to grow your business, but then also like have the ability to celebrate the people who are delivering the care. So I think that would just be like the plug that I would make. And then the second one would be listen to this podcast. So hopefully this is interesting. But our whole team listens to it all the time and shares episodes. We've got so much out of it. And I think it's really rare that there's a forum that I can hear from leaders across specialty pharmacy. And it's been like a huge education for me. So that would be my fully unsolicited plug to say goodbye with.
That's awesome. High five on that. That's a great ending to this. Well, Ryan, thanks so much for joining us, and we'll put out more shows like this with other great guests, and continue to do this as well. So, yeah, that's it for today. Thanks so much, everyone.
Yeah, thanks.